So, good evening, everyone. Today, I'm discussing a very short topic, acid-base disorders. This topic is very frequently asked in inicet and neet PG examination both. So, let's start now. So, I'm discussing first the normal parameters. So, first is the pH. The normal pH is 7.35 to 7.45. Less than 7.35 is your acidosis, and more than 7.45 represents alkalosis. Next parameter is bicarbonate. The normal bicarbonate is varies between 20 to 28 milliequivalents per liter. Optimal is 24 milliequivalents per liter. PCO2, it ranges between 35 to 45 mm of Hg, nearly equal to 40 mm of Hg. Oxygen saturation, usually above 95%. PO2, between 75 to 100 mm of Hg. Sodium level normal 135 to 145 millimoles per liter. Normal potassium range between 3.3 to 5 milliequivalents per liter. Now next, we will discuss the basic fundamentals of acidosis and alkalosis. So the basic fundamentals include acidosis can occur by two mechanisms, either by gain of acid or by loss of alkali. Similarly, alkalosis can also occur by two mechanisms, either loss of acid or gain of alkali. So there are two important points. Carbon dioxide is an acid which is mainly controlled by lungs, and bicarbonate is an alkali which is being controlled by kidneys. Now, any disturbance of carbon dioxide will lead to respiratory conditions, either acidosis or alkalosis. Similarly, any disturbance of bicarbonate will lead to metabolic causes, either metabolic acidosis or metabolic alkalosis. So these 2 points should be very clear in your mind, that any disturbance of carbon dioxide will lead to respiratory conditions, and bicarbonate it lead to metabolic condition, either acidosis or alkalosis. Now we'll discuss shortly about anion gap. Anion gap is usually calculated by a formula. So we'll add bicarbonate and chloride given in the question, and sodium. So we have to subtract the addition of bicarbonate and chloride from the sodium. So normal anion gap ranges between 6 to 12 milliequivalents per liter. This is a normal anion gap. So what is anion gap? Anion gap is actually the unmeasured anions in the body. So unmeasured anions in the body are anionic proteins. It includes phosphate, it includes sulfates and organic anions. So basically, anion gap is just the unmeasured anions in the body, and the normal anion gap you need to remember is between 6 to 12 milliequivalents per liter, and the formula to calculate the anion gap. Next, there is a important table From this, many questions can be solved. So first disorder we'll talk about is metabolic acidosis. Primary alteration, the primary problem in metabolic acidosis is there is decrease in the plasma bicarbonate. And what is the compensatory response? There is decrease in PCO2 with the help of hyperventilation. The patient will hyperventilate and will decrease the PCO2 as a compensation because of decreased bicarbonate. Next is metabolic alkalosis. The primary problem is increase in serum bicarbonate. So compensatory response of increase in bicarbonate is increase in PCO2 by hypoventilation. Next, respiratory acidosis. In respiratory acidosis, the primary alteration is increase in PCO2. And the compensatory response is increasing the bicarbonate by reabsorption by the kidneys. Respiratory alkalosis, the main problem is decrease in PCO2. And the compensatory response is there is decrease in bicarbonate by reabsorption by the kidneys. So primarily what is happening, that respiratory acidosis, we have to increase the bicarbonate as a compensation, and in alkalosis we have to decrease the bicarbonate. Next we discuss about the examples of each acid-base disorder. First is metabolic acidosis. So how to approach any question? First, check the pH. We'll talk about this later. First, there is just a general approach how to solve the questions of acid-base disorder. First, check the pH. If pH is less than 7.35, then it's acidemia or acidosis. And next condition can be pH either more than 7.35 or 7.45, sorry. So acidemia mein, then we'll talk about the PCO2. If PCO2 is more than 44, it's confirmed that it's a case of respiratory acidosis. If bicarbonate level is less than 20, then it's a case of metabolic acidosis. Now metabolic acidosis, further we have to check the anion gap. Now if anion gap is more than 12, then it's metabolic acidosis with increased anion gap. If it is normal, then it's metabolic acidosis with normal anion gap. Now we'll discuss the examples. Metabolic acidosis with increased anion gap. The causes are, there is a mnemonic, mud piles. So M, methanol intoxication, methanol poisoning, uremia, diabetic ketoacidosis, previously asked question. Then we have propylene glycol, iron poisoning or isoniazid, L for lactic acidosis, ethylene glycol poisoning, and salicylate poisoning. The late salicylate poisoning which lead to metabolic acidosis with increased anion gap. Now metabolic acidosis with normal anion gap. The causes are hyperalimentation, means when there is extra chloride. Next cause is renal tubular acidosis. Next important cause is diarrhea. Drug induced like acetazolamide or spironolactone, then due to saline infusion or due to uretrosigmoidotomy. The common causes of metabolic acidosis with normal NN gap is renal tubular acidosis, the important cause, diarrhea, drug induced like acetazolamide or spironolactone, and saline infusion. Now, pH is more than 7.45. The next category, pH is more than 7.45, then it's case of alkalosis. In alkalosis, next we check the PCO2 content. If PCO2 is less than 36 mmHg, then it's a case of respiratory alkalosis. So respiratory alkalosis, the causes of respiratory alkalosis are anxiety or panic attacks. This is one of the cause of respiratory alkalosis. Hypoxemia, salicylate poisoning. Salicylate poisoning early cases lead to respiratory alkalosis. Late cases leads to metabolic acidosis with increased NN gap. Then due to pulmonary embolism. Now next, bicarbonate if more than 28, then it's a case of metabolic alkalosis. Metabolic alkalosis, the common causes are due to diuretics. Long-term use of loop diuretics lead to metabolic alkalosis. Due to vomiting, as more and more the acidic content is thrown out, leading to alkalosis. Due to more use of antacids or hyperaldosteronism. When the aldosterone level goes up, like in Conn's syndrome. This is all about the general approach towards the acid-base balance disorders. Thank you so much.